My name is Nick. I'm a pain specialist physician. When I talk to patients, healthcare practitioners, medical specialists, you name it, a lot of time people are not sure about when to reach out to a pain specialist, when to seek pain specialist opinion and services. So I thought I'd put together something just to give you some indications on when to reach out to a pain specialist. It's a very important part of things, so I'm going to use a presentation with a couple of pictures. There are 4 big areas when to seek a pain specialist. One is for specific pain conditions and specific pain diagnoses, which I'm going to elaborate on, but we are proficient at diagnosing pain conditions and putting together a treatment plan. If medications are a factor or a problem for you, then you might think, well, this is time to get a pain specialist involved. In the perioperative setting, because surgery can be painful, of course, so moderate to severe surgery, or the patient factors might lead to you thinking, I need to have a pain specialist in my corner for this patient coming up to their surgery. And of course, within the allied health setting, when you're thinking about getting a multidisciplinary or a multiple different team members involved in managing this patient. So specific pain conditions, think about a pain specialist. So we're very good at assessing, diagnosing, treating specific pain conditions like neuropathic pain conditions, which is essentially bread and butter of what we do. So for example, some neuropathic pain conditions, the big one is chronic pain after surgery. Surgery's been appropriately done for the right reasons, no particular issues, the healing has happened, the pain stays, or it's a different pain, or it's a new pain. You've got to ask yourself, is this a neuropathic pain condition? There are some surgeries that are more likely to trigger neuropathic pain conditions than others, but effectively all surgical procedures can trigger neuropathic pain. The big ones might be amputation, thoracotomy, so opening up, spreading the ribs, that might trigger some pain. But sometimes even simple things as hernia surgery can trigger quite bad neuropathic pain within the groin region. Another big one is pain after spinal surgery, so-called persistent spinal pain syndrome, previously called failed back surgery syndrome, which is a terrible term, and it should be called persistent spinal pain syndrome. The surgery hasn't failed back surgery, it is just either triggered or the patient has persistent pain or new pain or worse pain. And this is a common area that we are called to help out for. Complex regional pain syndrome is a massive topic in its own right. Our understanding of it is always changing, always improving. So it's very important. If you've got somebody with potential CRPS, I really think that a pain specialist needs to be involved. The earlier, the better. If we get patient within days of triggering CRPS, say for example after an orthopedic surgery, we can cure this person. We have 3 treatment approaches for CRPS. You've got to diagnose it quickly, get a pain specialist involved, amongst other team members of course, and really get their pain managed quickly with multimodal routes of therapy. Another discussion. Neuropathic pain, this is, there are many types of neuropathic pain conditions. Post-operative neuralgia might be one, so pain after shingles, pain after zoster. Trigeminal neuralgia is a specific neuropathic pain condition as well, when that's pain in the face. Radicular pain is where there's pain in the arms and pain in the legs for reasons that you're not sure about, or reasons that have been treated, assessed. Patient's got pain down the leg, they've done some scans, they say it's all fine. Well, it's not all fine because the patient's got pain. So if anything serious has been excluded, you don't have a cancer, infection, prolapsed disc, that's good. Get them to a pain specialist if you can. There are strategies that we can use to diagnose the type of pain and modulate, treat the symptoms. Headaches, facial pain, we see a lot of people that have got migraines, headaches, nothing's responding, all the medications have been trialed, get them to a pain specialist. Visceral pain is pain within the viscera, so pain within the abdominal organs. Again, trauma, injury, surgery, sometimes for no reason, viscera can hurt and become painful, and it's generally thought to be a neuropathic pain. We're getting better at diagnosing, we're getting better at treating it. Pelvic pain falls into visceral pain because it's just pain within the pelvic and the organs of the pelvis. Endometriosis is a big one, of course. Again, if there are no surgical things that need to be addressed, if the medications are not helping, the pain is persisting, the pain is changing, the pain is moving up into the back, reach out to a pain specialist. Nociceptive pain is not neuropathic pain. So for example, joint pain, spinal degeneration. For example, if somebody's got arthritis in the knee, they're too young for surgery, they're too old, frail, or have medical conditions to go through with the surgery, or even if a patient just doesn't feel like they're ready for surgery, there are options other than just saying you're on your own, use some medications. We have ways of desensitizing joints. And another part of nociceptive pain is the muscle and covering of the muscle, the fascia, myofascial pain syndromes. People don't really think much of them, but they can absolutely be debilitating, and sometimes they even look like pinched nerves within the spine. They can reproduce themselves in some very, very odd ways, but we've got the tools to diagnose and treat that. I think you've noticed there that cancer pain is in all areas because cancer is a bit of neuropathic, it's a bit of nociceptive, it changes all the time. And if opioids and the cancer therapies and cancer surgeries and chemotherapy and radiotherapies are not helping and the pain is persisting, it is important to think about whether a pain specialist can support you, can support your patient in some way. We have tools. For example, a cancer pain of the abdomen of the pancreas can cause quite bad abdominal pain, but it can be treated with so-called splanchnic plexus blocks, radiofrequency, even alcohol, chemo, neurolytic blocks. So we have some strategies. And then nociplastic pain is this more wider spread pain. That is something to be considered as well. Pain medications. If you're struggling with medications, the medications are not working, you're not sure what medications to use, you're not sure how high to get the dosing, or the medications are interacting, think about getting a pain specialist. We see a lot of patients that have had medications heaped onto other medications over years and they end up on a bucket load of meds. And no one really knows why, no one really knows what's useful, so we can help simplify those medications. That's called polypharmacy. Of course, if opioids are a problem or opioid doses are not steady, they're going up, or if the opioid doses are quite high, or if there is an element of tolerance, the opioids are not working, or if there's some issues around opioids, then we can help. Sometimes it's something that you don't predict, it's something that you don't expect in terms of issues around opioid medications. Surgery is painful. So the perioperative setting, either if it's a big surgery or a surgery that is deemed to likely trigger pain, or if the patient is at risk, so the patient's got chronic pain or are on modest doses of opioids, even if they're having smaller surgeries, then there may be some strategies that you could get from a pain specialist. We're very good at working with anaesthetists, working with surgeons. Most of us are anaesthetists to start with before we become pain specialists. So we're very good at picking up the phone, working out a plan with a surgeon, working out a plan with the anaesthetist to make sure the patient has many non-opioid strategies as possible. Sometimes nerve blocks, ketamine infusions, using non-opioid medications can help patients get through the surgery safely. If a patient is vulnerable, in other words, if there's high levels of anxiety, they've had previous surgery that's been quite traumatic, they've got quite difficult to manage pain to start with, it is a risk factor, get a pain specialist involved. And of course, if somebody's taking opioids and they're on a modest dose and they're going to have surgery where they're going to require opioids, it might be a problem managing them over the perioperative period, so think about reaching out to a pain specialist in this situation. The allied health focus is something that everyone thinks about pain specialists. I'm not sure what to do. They've got anxiety, they've got depression, pain specialists. That's not all we do, as I've hopefully showed you. But yes, if a patient's got so-called maladaptive beliefs around their pain or behaviors around their pain, they protect themselves, they're not moving because it hurts. That's okay over a short time, it's not okay over a long time. If there's anxiety, if there's depression, if they're not coping very well, absolutely think about getting a good pain team involved. So most pain services have got pain specialists, physiotherapists, psychologists, occupational therapists, dietitians, and they've got access to even more a broader network rehab specialists, rehab pain management programs, so targeted programs, psychiatrists, addiction medicine. So it's the network that you're accessing really when you're seeking a pain specialist group or team. And of course, if they're not responding to first-line allied health therapies, then think about whether a pain specialist service might be something that could help. So I hope this has been helpful. I hope this has been useful. I think it's very important to think about when to seek out a pain specialist services.